Hey, how's it going, everybody? My name is Jalen,
Jordan.
Lilia?
and we are going to be doing our presentation on multiple sclerosis. So, to begin, we need to ask ourselves, what is multiple sclerosis? So, what multiple sclerosis is it's basically an autoimmune disease that affects your central nervous system. What it attacks is I know that what we've learned about neurons and nerves is that they have myelin that forms around their nerves, and what that essentially does is it helps you to get the signals to get across faster. Well, what happens in multiple sclerosis is that the immune system gets confused and it ends up actually attacking the myelin. This can cause inflammation, it can cause scar tissue lesions, and can also really impact the body's ability to be able to send those signals from the brain to the rest of the body. If you kind of look at this diagram, the onset and then the stages of multiple sclerosis, they're going to have different effects. So, for example, you might have some issues with like bowel incontinence. You can have urinary problems. You might have difficulty being able to talk. You might have spasticity. You might have flaccidity. Just go ahead and kind of take a look at this chart, and then you kind of see how it widely affects everything.
And also another big thing that I want to interject with that Lilia found out in terms of musculature. Later on in the presentation, we'll take note of foot drop, which is a very common impairment that you'll see with MS patients.
Yes.
Very true. So, what are the different types of multiple sclerosis? There are 4 different kinds. The first kind is relapsing, is that usually what happens for these types of cases is that they have very acute attacks. However, most of the time they are able to make a full recovery, but might have some residual effects right after they fully recover. The second type, I know it's in the third bullet, but we'll go ahead and talk about it. It's primary, and this is usually where they're having symptoms and then they're just kind of slowly going up. They might have some plateaus in there, or they might have no plateaus at all, but they're just kind of going right here and then they're just kind of slowly moving up the chain. Secondary progressive is kind of like primary, except one of the differences between the two is that instead of just slowly going up with that onset, they might have some noticeable relapses that might cause a bigger disability or gradually worsen with function. And then relapsing, this is the least common out of all 4 of the types. And usually what happens is that they are, again, it's slow progression, but there's, much like secondary, there's clear relapses. But most of the time, sometimes you can fully recover with secondary, but for progressive, sometimes you might not be able to fully recover from these different types of relapses. So diagnosis of the disease, how you can be diagnosed is through 4 different ways. It's either through blood tests, which they kind of just take a blood draw, and then they just kind of analyze the blood to see if there's different biomarkers within your blood that might link to multiple sclerosis. You can do a spinal tap, and this can show different abnormalities that might be happening throughout the body, or if it's having a different effect. It can also check for antibodies. An MRI, so that's basically like it's just they're taking a look at the brain, and it's checking for any lesions that might be in the brain or in the spinal cord. And then there's also invoked potential tests, and this is basically where they just kind of go and they record the electrical signals that are going on throughout your body, and then these detect for any kind of abnormalities that might be going on that might be linked to multiple sclerosis or any abnormal functions that might be going on. So what are you going to see in multiple sclerosis? Again, it's really going to depend on the symptoms and the severity. So the clinical presentation that you're going to be seeing is going to widely vary. However, the most common type of presentation you're going to see is paraphoresis. This can sometimes be found in 1 limb, 2 limb, or even all 4 limbs. There's going to be other symptoms such as blurred vision or difficulty speaking that you're not necessarily going to be seeing, but the patient is going to they're going to be complaining about it. So when in doubt, you just kind of need to talk to your patient and figure out what exactly they're complaining about. And like I said, it's going to depend on the severity and the progression of the condition. So for medical management, there's usually 3 different ways you can be treated for multiple sclerosis. One is through orally, either an IV infusion or even injections. So some of the medications that I'll talk about right here, one of the things like bedaserin, So what that kind of helps is it's just kind of helps with relapses that might be happening from multiple sclerosis. Generally, that'll be affecting either the secondary form or the relapsing form. Avonex, this one's actually kind of an interesting medication. What I actually found is it's kind of like if you're familiar with EpiPens, like if people are having anaphylactic reactions, they kind of just stick it right into their body, and then it helps like get the steroid in throughout the body to stop the reaction. That's kind of what this is. It's when somebody's having a relapse, what they can do is they can just kind of stick the Avonex pen in, and then it'll help treat the relapse. So if maybe they're having an episode of spasticity, they can just stick it right in, and then it'll stop whatever symptoms might be occurring. And then Mavenclane, that's an oral drug, and much like Betaseron, it just helps treat any kind of relapsing symptoms. So some YouTube videos that we'll go ahead and take a look at. So this first one we're going to be looking at is an intervention of multiple sclerosis gait with some balance impairments. So we'll go ahead and kind of take a look at that. So right here, it's just kind of a timed up and go. Go ahead and blow this up. Kind of see they're having difficulty trying to move that foot forward, especially on the left side. Might also look like they've got some synergetic patterns going on there too. And here's 9 months out with another front wheel walker. So doing a little bit better. And we'll kind of zoom in ahead just a little bit more. Now with just some canes, doing a lot more better. 9 months. Without canes. So without any assisted device.
To just swing the leg through. They don't have much eccentric control in the through. They might even have a vaulted gait or a circumducted gait as well.
So yeah, there's definitely some foot drop on that person right there. See kind of the thing again, they're circumducting just a little bit.
And then you get a little bit of that
Yeah. That is the next one, right here.
Transporting her into a car, she likes to shop, and so trying to take her shopping became a task. To move her legs, I mean, I'd have to use all of my strength. And now, after the pump, I mean, it's amazing. You can move her legs with, I don't use any of my strength. I mean, you could lift your leg, can't you, Mom? Mm-hmm. She never could do that. And her feet used to pretty much be straight down, and now
so
they're not completely flat, but they're getting there. And this is the part that has taken the longest is the feet, because the feet have had the most spasticity, but they are much better than they were before the pump.
So what they're kind of talking about there with the baclofen pump is that what that helps do is it helps kind of treat, again, the spasticity if they're having a synergetic pattern. It's kind of just helping all those muscles just relax and help being it, like, especially for the lower extremities where you're going to be seeing a lot more plantar flexion. It's going to help just kind of get that foot to dorsiflex just a little bit more. So you can even kind of tell in that video, like her foot was just like this the whole time, but now that it's able to move up a little bit more, now she can get more dorsiflexion. And then MS impairments, these are just some of the impairments. Some of these ones you've already seen on that previous diagram that I showed you in the second slide, I believe, but some other impairments like ataxia, a lot of them, if they're having weakness, they're gonna have difficulty moving, difficulty balancing, same thing, proprioception, especially if they have a synergetic pattern. Spasticity, same thing. Temperature sensitivity, this is an interesting one. So from what we saw about temperature sensitivity, I believe it's nothing higher than 83 degrees. Anything more than that, and you risk having somebody relapse or having an acute relapse. acute or chronic pain, tremors, visual deficits. Again, it's really ultimately going to depend. And then 85% of people with multiple sclerosis are some point going to experience a flare-up. All right, without further ado, let's go ahead and have Lilia show you the next few slides.
So, fatigue is the most common and disabling multiple sclerosis symptom. Patients with multiple sclerosis can experience fatigue related to the disease process, or in other words, due to demyelination or poor nerve messaging. Second, fatigue, when people become less active due to primary fatigue and they live on a progressively less active lifestyle. So what makes exercise difficult? It's kind of, yeah. So it's variability. It's not this slide, actually. I don't know.
Just
Okay.
Did you want me to go to the next one?
Okay, I will just go through my notes. So variability, what does it mean? Exercise is different for people with multiple sclerosis and for people without multiple sclerosis, obviously. It's very different cases. It depends on the location of the lesion. And exercise can be a treatment for specific symptoms of multiple sclerosis. You can tell to the patient, I'd like you to think about this specific exercise as for type of the medication. If you'll do this exercise, then certain symptoms going to respond. If you don't do this exercise, the result is the same as when you didn't take your medication. Don't expect to be improvements. Second difficulty is neurogenic fatigue that I already explained before. The third one is a thermosensitivity. It's
Sorry, okay.
So just to clarify, these are impairments and difficulties on top of one of the greatest one, which is going to be a functional limitation being ambulation. These are also additional difficulties and impairments that they're going to have along with their ambulation.
Yeah, I will talk about the ambulation
increased
there.
stability and postural sweat.
Yeah, it's just we have another slide. It's kind of I don't see it right now. The third one is thermosensitivity, heat versus symptoms of multiple sclerosis, like Jalen already said. So here's heat-related onset of the blurred vision, increased paresthesia or overwhelming fatigue. It is considered pseudo-attack of the multiple sclerosis, and it is resolved when the body temperature returns to normal. So therefore, very, very important to control the temperature and keep it cool. Women use some kind of fans when people are exercising. Heat can be internal too. Exercise raises core temperature. There is a myth that states
PT concerns and interventions. There we go.
that's not this.
Okay.
I
All right.
don't see that slide for some reason. There is a myth that states that patients should not exercise aggressively because it may lead to exacerbation of symptoms, stated Howard Rusk. However, there was a fatigue study done in 1996. 54 people with multiple sclerosis were participating. They performed 40 minutes of aerobic training 3 times a week for 15 weeks. The results showed that improvements in strength, aerobic fitness, and body fat in exercising group. The other group of people without MS who was also participating in this study showed similar improvements. There was no increase in exacerbation. However, in the control group who didn't exercise, of course, they didn't have any improvements.
So something that we wanted to add as well is that according to the evidence-based practice that we found in this NCBI article, it states that there are additional myths, like Lilia was saying, that exercise is not recommended because of this thermosensitivity. However, that has been debunked as of recently. Recently, according to research journals, they say that exercise prescription for patients with MS is a practical recommendation, as long as you're following guidelines such as Lilia's going through here. So what we'll do is we'll slide past a couple of these. We're going to go straight into the concerns and interventions. and we're going to address some of the impairments and then go into the functional limitations. Okay? So you're going to notice that there's cardio issues, muscle strength issues, difficulty with walking, spasticity, which we'll address later. We'll give you an example.
Especially with those synergetic patterns.
Absolutely. You're going to have early fatigue, as Lily was saying. Their cognition may be a little impaired. You're definitely going to see decreased breathing ability as well as foot drop. And then we're going to continue with a functional.
Oh,
Intermittent
And
continuous.
I want to talk about functional limitations. It's before slides. That's this one. So people with multiple sclerosis will have an ataxia, which is difficult coordinating in movements. There are specific weighted vests and belts that people with multiple sclerosis can use for proprioception. These vests are helpful in providing stability. Also, holding one limb in the mid-ranges and weight bearing with some controlled weight shifting can be beneficial. Also, PNF techniques that we will show you later are also very helpful with this problem, including alternating isometrics, rhythmic stabilization, and slow reversal holds. Another, like when people with MS are walking, they can develop compensations to increase stability. Those compensations are widened base support, knees are stiffened, and bending the knees, which is lowering the body center of gravity. Moreover, they have an increased postural sway, arms are counteracting. If sitting, person leans on an outstretched arm to provide stability. So intermittent,
Aha, right
yes,
here.
this one. So intermittent versus continuous exercises. What is this? Most exercise programs are performed continuously without rest. During this exercise, body temperature rises and fatigue occurs. The harder the person tries to exercise, the worse the performance gets, and the less exercise occurs. However, intermittent exercise is completely different. People take rest during the exercise, and it diminishes the heat buildup and allows fatigue to dissipate. Therefore, the intermittent training allows for a greater volume of work to be performed. This information is very important for us as a future PTAs. We need to teach our patients to take break before they think they need a break. There was a study done by Hunter College, it's still here, about intermittent versus continuous walking. In the first trial, they let people with multiple sclerosis, which were 27 subjects, walk for 6 minutes continuously without rest. And they measured a distance and their fatigue level. The mean distance of people who walked continuously was 932 feet. The other trial, the same 27 people walked for 6 minutes in 2 increments with 2 seated recovery. Like they walked for 3 minutes and recovered for 2 minutes. The result was much better. Their distance was 1,112 feet instead of 932 feet. And these people didn't have fatigue at all. So what does this research suggest? To improve walking distance, take breaks. Therefore, intermittent training is better for people with MS. Yeah.
Renkel's exercises.
Renkel
right here.
exercises.
Perfect.
So what does it mean? We use this information from our book, and it's on page 477. It is very useful tool to practice with multiple sclerosis people. These Renkel exercises can be done in lying, sitting, standing, and walking. So we will show you some of them, and the rest you can just read and practice yourself.
So let's come on over to the mat.
Okay.
We're going to demonstrate.
And now what I'm going to do is I'm going to give them the mic, and then you're going to see what we're talking about. There you go. And I will go ahead and use the camera.
Okay.
Okay,
Go
that
ahead,
should be appropriate
Jordan,
right
and
there.
lie down on your back. And I will. Okay. Yes. Yes. You are right. So everybody will see. So first one is, Jordan, you need to flex and extend one leg, heel sliding down on a straight line on the table. So
Okay,
flex.
Lilia's going to
Yes.
demonstrate.
So flex and extend. Make sure that your heel is sliding on the table, and you need to do it very slowly, okay? The purpose of this exercise is to do everything slowly, okay? So the second exercise is abduct and adduct hip smoothly with knee bend, heel on the table. So Jordan will flex the knee, and he will abduct and adduct hip while keeping a heel sliding on the table, okay? And we will do for both legs, but for today, we'll just show just for one leg. The next one is abduct and adduct leg with knee and hip extended, leg sliding on the table. So Jordan will extend his leg, and we will just slide to abduct. Make sure that your points, your toes are up to the steering. Like this. Okay, and the next one we will show you to place one heel on the knee of opposite leg and slide heel smoothly down shin toward knee, ankle, and back to the knee. So what it means, so you will flex the knee, and you will slide your heel toward the ankle and back, and you will do very slowly, okay? You will do a few times, okay? That's it. That we will. You can read and do the rest.
Okay, very
Yeah.
good.
All right.
Okay.
We'll have more to demonstrate
Yeah.
in a short time.
There we are.
Thank you. Give me a second. I'm blowing people's ears out real quick. There we go. That's what I'm looking for. We'll turn that down a little bit. Sorry for the guerrilla style photography, everybody. All right. There we go. All right. And skill pyramid next. I think we got Jordan.
So, what we're looking at here, folks, covers in all bases of skilled physical therapy in general, whether acute care all the way to outpatient ortho. We want to follow the skill pyramid. First, you start with mobility. That could be working sit to stand, standing balance. You just want to get the patient movement, just initiating some sort of movement. Stability. Here's where you're trying to stabilize proximally. So the idea is you can do anything like rhythmic stabilizations. You can do alternating isometrics, approximating at the hip, at the shoulder. You're trying to make them feel grounded, trying to make them feel stable. Controlled mobility is essentially where we're doing something like a weight shift. You want to have movement while having this stability as well. You can do things like moving their body with their cone, doing that to stabilize with different types of ankle strategies, focusing on balance, just weight shifting side to side, make them do a short reach, or even like our spinal cord injury checkoff where you can shift to the side, put the hand in the lap, try to move their hands closer to their body. And then skill, this is where you're doing things like a weight shift and some sort of activity. You can do a march, leg swing while standing, leg reach back. Essentially for MS patients, you really want to focus on gait. That's top priority. That's going to be top 5 intervention. So whatever we're trying to do, we're trying to do a skill with the lower extremity specifically because you want to work on what you have. So this is the reasoning behind the interventions that we chose. We're stretching because we want to focus on spasticity. The one thing you're going to see is highly painful contractions. This is something that even with my own experience working with an MS patient, they're always complaining about the pain, and it's due to these tight contractions. So you want to work on gentle stretching. Balancing exercises, we're doing that to reduce the rate. I believe in some articles that I was reading, it's about 50 to 60% fall rate post-MS. So this is top priority. We need to start addressing balance ASAP. In terms of strengthening, you want to prioritize with the legs rather than the arms. Yes, we know that to do life, you need upper extremity. However, they can get by with an impaired arm and then and a functional arm but you can't get by very well when you're not walking. That goes back to prioritizing. We need to focus on their lower extremity deficits before, while still trying our best focus on upper extremity as well, which we'll go into with some of our P&F techniques. In terms of aerobic exercises, let's say outpatient, you can deal with upper body ergometer, just get the arm moving. You can do lower extremity bike. Someone who's very low level, we can get them in the pool doing aquatic exercises. You can even, with a more advanced patient, when they're working on normalizing gait and getting rid of that painful gait, you can do things like treadmill. So these are the PNF NDT interventions that we are referring to that we're actually going to show here right now. Upper extremity, you can do slow reversals with holds as well as D2 flexion extension. You want to be in supine and seated. These are shown in research to be the best positions, as well as lower extremity. You can do hold, relax, contract, relax. You can even do protraction, retraction with the pelvis, which are excellent. You can do that sideline. So let's come over here again with the mic. We'll face the camera over one more time.
Fix it over one more time for you guys so you can all see.
Thanks, Sharon.
You are very welcome.
Okay, if you would, Lilia, go ahead and
some
lay
PNF.
down on your back. Head is going to be up facing this direction, please.
This way, right?
Perfect. Perfect. Okay. And so the camera can see, we'll demonstrate on this side. This is going to be the affected arm, okay? I'm just going to start by initiating. Okay. Can you show me how your shoulder is moving today? Okay. So essentially what we can do is you can just help the patient go through the motions, okay? You want to tell them exactly what you want them to do, as well as take them physically through the motion for that rhythmic initiation. Now, Lilia, what I'd like you to do is I would like you to meet my resistance, okay? So what I'm gonna do is just give you a little bit of proprioception there by aggressively, but you don't wanna hurt your patients, but still aggressively slap your hands to the palm as well as the dorsal surface, okay? Meet my resistance, okay? Meet my resistance, all the way down, okay. Now, when you're at the end range like this, now I want you to hold. Hold, slow reversal, hold, isometric, hold for about 6 seconds, which is proven to be most effective, okay? Okay, all the way, hold. You wanna make sure you're at the very end range, okay? For it to be completely effective. Hold. Again, meet my resistance, hold, okay? Wonderful. Now for lower extremity, we're gonna focus on another technique that we learned earlier in the program, which is contract relax. This is excellent for someone who has very spastic hamstrings, which you may see as well with lower extremity. So I'll just demonstrate on this side. It's a little bit easier to see. Okay, Lilia, I'm gonna lift your leg, okay? I'm gonna put it on my shoulder, okay? And then I'm gonna slowly come up. I want you to push your heel down into my shoulder. Hold. Same thing, you want a 6-second isometric contraction, relax.
So yeah, Jordan's just using his shoulder as a block right now for Lilia's leg.
Okay, go ahead and hold. Keep holding and relax. And then the idea here is you're using the patient's muscles to your benefit. Okay, push into my shoulder, hold. So they're doing all the work. You're just blocking them and relax. And then it's forcing the hamstrings to elongate and relax. Again. After you do an isometric contraction, go ahead and relax. Then it forces it to relax. And you want to do that until you notice an increase in range of motion. Okay, excellent.
All right. Turn the mic down so we don't blast you guys.
Let me go ahead and move this over to me. Oops. There we go.
Perfect. Back to the presentation. Perfect. All right.
Okay. So we just showed an example of a contract relax, which would be an excellent way for stretching. You can do that with multiple scenarios. It's not just hamstrings. You essentially want to stretch what's going to be mostly affected, which is going to be neck extensors, anterior shoulder, hip flexors, hamstring, which we just demonstrated, hip adductors, plantar flexors, and you really want to get in a bit of trunk rotation as well because they're going to be really limited in that area, similar to Parkinson's almost, very limited. Balance coordination, this I'd say in our top 5 is going to be either top 1, top 2. Balance is going to be key. Excellent examples we'll show later on. We can do Swiss ball training, just having the patient sit on the ball. Yoga, Tai Chi, which we also learned that you're able to do Tai Chi in aquatic therapy. So you can kind of mix and combine and match some of these different styles to create a creative and innovative exercise plan for some of your patients. It's all in what they're going to need. However, keep in mind, in terms of what Lily and Jalen were saying, make sure the temperature in the pool is approximately 81 to 83 degrees so you don't induce any onsets of symptoms. Also, something that Lilia had mentioned is if you're in a gym, maybe outpatient orthopedics, make sure that you're applying fans to your patients as well. It's very easy for them to overheat. Foot drop interventions. So we can actually just demonstrate right here.
So as we can all know that people with multiple sclerosis have foot drop, and we need to help them to get them stronger. So Jordan will demonstrate some of the activities. We need to stretch the plantar flexors.
There we go.
And for that, we will use heal the
Okay, so
belt.
plantar flexors, essentially, it's not perfect here. Work with me.
We'll work with it.
But
Okay, we're right here. You can do it seated, but what you'll
we
do
have a
is you'll have
gait belt.
you
there.
can use a gait belt, or you can use a dog leash.
Yeah, and we
Prefer
can,
a gate belt, not a dog leash, please.
so we can
do
have a
any of both.
seated gastric stretch using belt 2-3 times, and you will hold for 30 seconds. And also we need to strengthen dorsiflexors, so we can do seated. So you're done with this.
Right. So then the patient will be seated.
Seated,
Okay.
and
In
you will-
perfect worlds with a good position, they'll be seated normally, and then you can lift the toes up as such.
Yeah,
Okay.
you will hold your leg down usually, and you will just
So this will hit dorsiflexors, and then we can do heel raises as well to the best of our ability.
Also for balance training, we will sit on a Dynadisc, but the Dynadisc is in a lab room where
That's
the
okay.
checkout.
So pretend that
Okay.
we have a Dynadisc. We'll put the
Dynadisc.
Dynadisc
And
underneath.
Jordan's foot's supposed to be on the ground, sturdy
Just use my leg.
surface. And upper extremities are on a sturdy surface as well. As Jordan will get better, he can lift his hands.
No upper extremity
Yeah.
support, then they'll be all over the place. It's going to force them to use more of their trunk, create more stability, better seating balance. So when you progress to better seating balance, then we can eventually progress to standing balance
yes.
towards stability and balance while in gait.
Okay. All right.
Perfect. Let's go back to the presentation.
And we have
Okay,
muscle
so I also read a research article which was interesting. It's saying that advanced MS patients actually are recommended to have IMT training. We had, I believe there were about 20 to 30 patients that were involved in this with MS, all with advanced MS that had gone through a 10-week IMT training, and it proved to increase breathing ability due to increase in inspiratory muscle strength. This was demonstrated after about 8 weeks. So according to research, it takes about a solid month and a half to 2 months before you start seeing big improvements. But they all did really well with that, so that's highly suggested. Something also I wanted to cover, which I thought was fun for the presentation, is that there's actually brand new research with MS that they're just trying as of 2020. We're talking maybe about 1 to 2 months ago. So this is state-of-the-art technology. There's IHSCT training. What it is a type of transplant. What you're able to do is you're able to inject the serum and it repopulates the immune system. So it basically unconfuses the immune system and it resets itself so it stops attacking itself.
That's nice.
So we thought it was pretty cool. According to the director of the whole project, medical doctor, they said it has the potential to progress relapsing MS and eliminate the need for medication. So I don't know about you guys, but that sounds something like I'd be interested in.
Yeah, just kind of right there, the research article and all that.
Yeah, absolutely.
We can post a link for you guys if you guys request it.
Yeah, it's very cool. And then Jalen's gonna
Oh,
finish
hey,
with a
case study. Yeah, we're going to finish it up with this. All right, I'll go ahead and sit down. So, case study. A 54-year-old woman suffering from multiple sclerosis, upper extremity strength 3 out of 5, with lower extremity 3+ out of 5. She experiences difficulty walking around her house due to severe ataxia, and also immediately suffers from random flare-ups of shooting pain that radiates down from her neck to the rest of her body. Additionally, she also suffers from intermittent dystonia, which causes her legs to go flaccid. Her symptoms are mild. The symptoms are mild to moderate and usually go away after a few minutes. She's been referred to PT in order to work on gait and pain control.
Okay, so some of the common case study interventions, it's going to go back to everything that we just talked about throughout the entirety of the presentation. Pretty straightforward. You want to address standing static balance, okay? So let's say you do something as simple. May you be my demonstrator?
Try to move out of the way for you guys.
Okay. So let's say the patient is, let's say the patient is well enough to stand. They're going to have a 3+ strength, so clearly well enough to stand. We recommend that you stay at the parallel bars, okay, in your clinic. What you want to do is have them, Lilia, bring your feet close together until they're touching, okay? That will challenge their balance a little bit, okay? And then you make sure that you want to guard. Obviously, you're going to have the gait belt on. When they start to progress, go ahead and put one foot in front of the other. You can progress to tandem balance, tandem stance, eventually progressing to single leg stance. If they're not quite there, you can lift one heel off and give support with the other so they're both in closed chain. There's multiple ways to address standing static balance. In terms of stability exercises, what you're able to do is use a lot of the P&F techniques that we learned in class. So let's say you're doing gait training. We're at the parallel bars again. What we're going to do is we're going to address the pelvis, the shoulders. Make sure there's proper rotation. You're gonna see a lack of rotation. That's going to decrease their stride length. So Lilia, go ahead and step forward with this foot, okay? Notice how she doesn't rotate. So come back, step forward again. What you can do is, Lilia, step forward, okay? And then initiate that pelvic rotation, okay? Coming forward, you're gonna protract and then retract, okay? That's gonna help increase stride length. While you're doing that as well, before you start, Lilia, I'm gonna apply a little bit of pressure through the hips. You're gonna approximate. Does that feel stable?
Yes.
Very good. So there are a lot of simple things that we already have learned throughout acute care as well as advanced rehab. So we highly recommend all of the P&F techniques. Something interesting though.
Yes, something you, again, need to watch out for. You need to watch out for that sudden flaccidity. This can mainly happen, especially in this case, in the lower extremities. So if you're doing gait training with somebody and all of a sudden they start falling down, they're getting weak, you need to make sure that you're there to guard them and that they're not going to, hit something and cause themselves to get damaged even more or cause themselves to get injured from having a secondary complication. That's going to be very important. Just make sure that happens. Always be guarding even when it looks like that they're doing amazing because you never know when that dystonia is just going to randomly kick in.
Absolutely. And something that we also noticed while watching the videos earlier during gait training, follow behind them clearly they're going to have a gait on or gait belt on, but you also want to follow behind with the chair. You never know when they're going to drop.
Yeah.
As well as when you're at the parallel bars, another thing we're going to do, simple weight shifts. Just weight shift and then have them step forward, addressing that rotation.
Yeah.
Okay?
Yeah, we will show the trunk rotation with the ball.
Yeah, absolutely. So follow us over here,
All right,
guys.
we'll
We got a
show
couple
ya.
more exercises.
Show you one more quick thing. And I'll give you guys a mic. Here you go.
And Jordan will lie down on his back and put his legs on the ball.
Oh,
Oh, we're good.
Okay. What we will do, so the ball will have the leg of Jordan's legs, and we will do slow trunk rotations from side to side. And it will help to reduce the tone in his trunk and pelvic girdle muscles. Okay? We'll do for a few times. Okay? And the other exercise is really good for people with MS. We'll do bridging. So you will put your legs on the ball, or actually this is good, and you will just elevate your hips like this and down. This will strengthen his hip muscles, which is really important for stability and mobility of the patient. Okay? Okay. So the other exercise that's really good for people with MS. Jordan, you will go on a quadruped position, so on your hands and knees. Yeah. And what you will do, you will just do this side sitting. So from side, and you will do very slowly, slow trunk rotations, okay? Yeah, from side to side. That's really good stretching for all.
yeah,
these
that feels good.
muscles. Yeah. Yeah. Good. Okay. Did we miss something?
Also, last thing that I just remember that we could do with the Swiss ball, trunk rotation with the Swiss ball.
Yeah, we just did, right? Trunk rotation with
But you can also do it with the Swiss ball as well.
yeah.
Did we already do it?
We just did
Oh.
first exercise.
Wrong day.
Whoops.
Okay.
We had a brain fart.
Just kidding. We already did that.
All right. Go ahead and put this back on the laptop. There we go. And we'll go back to the presentation. Sweet. Oh, and my mic's wonky.
Okay.
And yeah, here's our sources.
That was everything. Thank you
Um,
so much.
Thank you.
Thank you. If you guys have any questions for us, please don't be afraid to leave it into the discussion. And then hopefully the discussion question will be up soon, and then you guys can go ahead and answer that.
All right.
And we will answer accordingly. All right.
Okay,
Yeah,
talk
thank
soon.
you.
Talk to you guys soon.
Bye.
Bye.